Welcome back, everyone, to the Nurses Station. I'm Tim Cunningham. I'm our host for this week. We're doing this cool thing where we're going to rotate hosts from week to week as we come together, Dr. Chicas, Dr. Dunn, Dr. Clevenger, to talk about hot topics around nursing. Last episode, we touched on how broad nursing is. We talked about our experiences, what brought us to the field that I'd say, I don't know, someone cut me off, that we're all deeply passionate about and excited about. So we're excited to spend some time with you all to share some more ideas and to talk about some of the challenges and some of the hard things that we're facing as nurses. This podcast is going to happen bi-weekly. It's also a webcast. So if you've got access to a screen, turn it on, because I think we're pretty nice looking people. And sometimes we do some goofy things that you might not be able to hear on a podcast. So jump on board. You can find us at nursing.emory.edu. Again, that's nursing.emory.edu or wherever you watch podcasts. And you can get show notes if you jump on our LinkedIn group, which is called the Nurses Station Show. Like I said, we've got Dr. Roxana Chicas, Dr. Alexis Dunn, Dr. Carolyn Clevenger, and my name is Dr. Tim Cunningham. Lexi, how you been doing the last week? What's going on in your world?
Well, Tim, or Dr. Bumble. Don't forget your real name.
my real official doctor name.
Your real name is Dr. Bumble, but I'm doing okay, Tim. It's kind of a busy time. I'm working on some manuscripts, a grant that just came in, and just trying to get my scholarship on board as far as work. On a personal, just trying to manage being home with young kids and trying to work. It's been a challenge, but I'm in good spirits overall.
It's so great to see you again, and
you too.
Glad you're hanging in there.
Yeah,
Dr. Clevenger, tell me about your world.
Yeah, so on the professional lens, I've got these two big areas that are still kind of every week's a different week. I'm responsible for the clinical placement of all of our nursing students. And it's really hard to place them in healthcare settings when healthcare settings are also struggling, either because they're extremely busy or because they have not much going on, or they completely converted to a new way of delivering care. So trying to figure out how to do that and then bringing a student in is tough. So then our students then are also, of course, super stressed about getting that. Nobody wants them placed clinically more than I do. And then, of course, at our clinic at Integrated Memory Care, it continues to be, it's just really hard on our families right now and our patients still. We're having a slightly better week right now. We getting all of our telemedicine visits in. People are finally are converting over to doing care that way, kind of getting used to it. But, I'm the clinical director, and I just got our reimbursement rates from a few months ago when visits were terrible. We're primary care. So we're kind of navigating through all of that. And I have kids at home who are trying to do digital learning. And so it's all the Zooms all the time right now here.
I just changed my alarm clock. I don't know if you're all familiar with that Bowie song. Every morning when I wake up, whatever hour that is, sometimes it's 3 a.m. if I'm going to meet with nurses on the night shift, or if it's 5 a.m. or 6 a.m., whatever, I wake up to the song, changes, because that's the world we're living in. Everything.
Mm-hmm.
Dr. Chicas, what changes have gone on in your life in the last week, and how you doing?
Good, and you?
I'm hanging in.
I see that. So I am still in Florida doing data collection with agricultural workers. So this is, for me, it's really fulfilling to be in the community with, essential workers who continue to work and put food on our table. So I'm super excited to be here. And also I get to kind of navigate the challenges of doing research during COVID-19 pandemic. Yeah,
that's so great to see you again. I'm jealous of your overground swimming pool as well. And wish I had one of those as we're swimming.
Too. I need something to get in. Anything.
Right?
I'm thinking about running through the sprinklers. I just need something.
Yeah, anywhere. As long as they're safe, right? Yeah. I'm wearing a new bow tie today. I love wearing bow ties. I kind of work in a place where a lot of people wear neckties and those sort of long ties, and bow ties. I got a little splash. But today, if you can see, I've got some elephants on this bow tie.
Oh wait, Tim! I have elephants in my room. Look.
What?
You see them?
Oh, yeah. Where are
Yeah.
those from, or what are elephants to you?
Well, I'm in a sorority. I'm a Delta, so we can get into kind of cultural things, but I'm Delta Sigma Theta is my sorority, and the elephants are one of our things that we collect, and it's a symbol of good luck.
Yeah.
So
Awesome.
I love elephants. I have several, actually, maybe like 30.
I love them. My mom collects elephants, so I think about my mom when I wear this, and I think about these wise, brilliant, amazing animals. I think it's also appropriate that we're talking about elephants in your room, because we all got an elephant in the room, which is COVID. And maybe it's not even an elephant in the room today, but today we're going to focus our entire cast on COVID. And it might get heavy. And I think that's the beauty of nursing. We can go deep, we can stay up high, and we can go all the way around as we talk about this thing that is affecting every single person on the planet. I'm pulling up stats for today. Now, of course, we're recording today, and you might hear this on a different day, but as of today, across the globe, we have 2.3 million confirmed cases of COVID, 741,000, that's 741,000 deaths by COVID.
Wow.
Before I had this job, I did a lot of global health work, and I've done some work in South Africa, also in Sierra Leone, in West Africa. And while I was working in South Africa, I took some time and was able to travel around and go on a little safari, and I got to see some elephants. And so also, when I wear elephants, I think of my colleagues living and working on the continent in a place where we also know we don't have the testing that's going on. So we don't know really how many people are sick and how many people are dying across the world.
And Tim, I bet you that number is probably higher, just even, when they started tracking this thing. I mean, it's COVID-19, right? But, we didn't really get on board with kind of tracking it well into 2020. So I imagine those numbers would be even higher.
Absolutely. And we think about access to tests and decisions made on sharing data. Data is a pretty solid thing, but, COVID's been a little politicized as well. So how do we really know what's going on, and how do we make those decisions? So as we talk about the decisions that we've been making, I first want to hear from you all in your professional scope right now. What is COVID doing to your work, and how has that affected your work? Roxana, do you want to jump in and just let us know, how has that affected the things that you do and the research that you run?
Yeah, so our research did have to stop for a little bit because of university policies, right? Not allowing us to do research. But now that we are able to do research, we've come to Florida. The agricultural workers here have continued to work throughout this pandemic. They feel like they have to work. It's so that they can put food on their table for their kids and families. And so what I've seen is that even though they're an essential workforce, they are not getting the proper protective equipment at their jobs. They don't have much access to getting testing. You would think that as an essential workforce, they would have priority testing, and that's not happening. And I think that the testing that's going on right now it's reaching some populations very well, but it's not reaching those in the service industry, and immigrants are having a really hard time getting tested because in some places you have to have a social security number in order to get your results. And so if you have no social, you don't get your results, and there's no point in even getting tested, right? If you need that. So it sometimes feels systematic that's happening, and hopefully we can come together and find a solution to helping our most vulnerable populations and the ones that are really kind of help us, live our daily lives.
Yeah. And it seems like when we talk about our most vulnerable populations, if we think about the HIV/AIDS epidemic when it hit New York City and the US, when we think about Ebola, when we think about some other pandemics, we used to say the vulnerable populations are our nurses, our physicians, the frontline caregivers. With COVID, because it is a true pandemic, our most vulnerable populations, it seems, at least in today's age, are the folks that have least access to testing and least access to care. And how we manage that. I think about moms having babies. I think about access to care. Childbirth can be a very dangerous thing if you don't have the right access. Lexi, are you seeing challenges and changes along those lines?
Oh, big time. I mean, if you just talk to moms or either nurse midwives or practitioners, it is a very disorienting time. You know, moms and families are very scared. They don't want to come into hospitals, especially because they know that there are a lot of COVID patients in there. They have these newborn babies. And so they're facing challenges of wanting to come in for care, but not wanting to expose themselves or their babies. And so there's a lot of fear there. I think it has also intersected with the racial tension that's going on in our country. So for BIPOC, which is, I'm gonna make sure I define this.
Oh, we almost got you.
Black and Indigenous people of color. You thought I wasn't going to do it, but I
was about to pounce.
I know you were.
$1.
But for those women and those families, it's even more scary because you have a distrust of the medical system, but you also have these fears. And so as practitioners, I know I work at the Atlanta Birth Center, PRN, as needed. PRN means as needed. I don't know how deep this acronym thing goes. And one of the things that we're doing is we're having these special group prenatal visits online and social support for moms of color or for anyone that feels that they need that extra support. So we're trying to do our best to maximize the virtual environment to kind of give women what they need. Practitioners are tired, they're exhausted, we're in PPE in a birth. I mean, birth is very personal. You have to connect with the mom, and that connection and that safe space that we as midwives create, it is hard to do that when you have to have on all this gear all the time. And it's all these procedures about how you interact, so I think it is a very hard time for both practitioners and families right now.
And so I'm hearing emotional burden. I'm hearing physical burden. I'm hearing, I'm about to call you out because you said PPE. It didn't say what that is. Being the host today, I'm going to be extra strict, personal protective equipment.
You're so close.
I mean, you were close. I mean, you were 2 for 1.
Oh, it's so good.
2 for 1 is not bad. And I almost let it slide.
Listen, Tim, they've been talking about PPE in the mass media. I mean, I think everybody knows what PPE is. I think it has crossed over. A word.
I mean, that's a valid argument. I think unless we had live polling of everyone listening at the moment, we couldn't really understand whether everyone knows or not. So
I'll put $1 in.
All right, we'll take that $1. We might flub up. Maybe. Hey, just a reminder, everybody, we are playing a game. It's an acronym game that we created last episode because we realize in the nursing profession and in healthcare, there are a lot of acronyms. And we might just spout off a bunch of letters and realize that not everyone in our audience knows. So we are playing a game in which we're going to call each other out. If someone says an acronym like PPE, but doesn't then say, oh, PPE means personal protective equipment, we're going to call them out and they got to put $1 in the pot. And at the end of this season, we're going to bring all that money together and give it to me.
Right? No, give it to me.
No, I don't think that's bad. No.
Well, we'll have to. All right, we'll figure it out by the end of the season. But yeah, physical burden, emotional burden. It's so tough. And thank you for the work that you're doing on it, all of y'all. Carolyn, tell me about the work as it relates to nursing education, right? Because we still need new nurses.
Right.
We still need to prepare our nurses. But how do we do that when they're walking into the fire?
Yeah, it seems to be all over the place in terms of the students and the places where we typically train them. So, in some environments where there is a lot of personal protective equipment available, or even if there's a concern about that. So we've been supplying our students, but that's a short supply. Yeah. And we have, the science change. It feels like the science changes every day, and we do learn things. We're continuing to learn about what's effective and in terms of personal protection for ourselves and for our patients. But there's still, because it's not, I think, established, we certainly have students who are personally concerned about their own safety. So, they're making that difficult decision about completing educational requirements, but also the risk that they're taking on. They may have personally themselves have high risk conditions. They may be a caregiver for someone in their home who is immune compromised or who has other high risk situations that make them have to make some really difficult decisions. Now, we're fortunate that for people who are preparing to be a registered nurse, so we call them pre-licensure, they do have a few other options, and it's kind of an interesting intersection of technology where they're doing virtual reality to learn how to care for patients.
Wow.
This does back to kind of what we talked about in our previous episode, which is if you think that nurses are defined by doing what they do versus what they are, you really have to wrap your head around a student during virtual reality clinical, because they're not necessarily doing something with their hands, but they are thinking like a nurse, which is really core of what nursing education is about, thinking like a nurse, thinking like an advanced practice nurse. So maybe they're getting, better training in that area, but there are trade-offs to not being in that actual environment, because getting into those environments is really challenging.
Yeah, and that's thinking like a nurse, advocating like a nurse. And then doing. And that's a great thing about our profession, because we are as hands-on as we are cerebral, and we have to find that connection. And I hear you on the access to students. One thing that my office has been working on and team has been working on collaboratively, not just school of nursing, but school of medicine, are students that come in as social workers, as chaplains, as occupational therapists. We want to bring them on board, but first and foremost, we want to make sure they stay safe. And so a big conversation is, do we have enough personal protective equipment? Can we say PPE now that we've said it 3 times out loud?
I think that's fair.
Oh, no, you can, no.
Go ahead. You can use it. You can use it, Tim. It's okay.
No, that's
I'm just
okay.
feeling my feelings. I'm just trying to get over it.
I just got side-eyed by Lexi. So no, we're going to say personal protective equipment every single time. Game.
No, you can do PPE. I promise it's okay.
So we're worried about having enough personal protective equipment. And we're also worried about our nursing students making sure that they're supporting the care given and not getting in the way. Because a lot of our clinicians are also really, really stressed out. They're so focused on the patient. They're so focused on the safety of the team. It's this like big picture thinking that I think in the US, we've never had to do when it comes to healthcare. So it's always changing, always in flux.
I have a question for you, Tim, though, but where's the line with that? Because I feel like, we still have to train up a workforce, right? And what I've been hearing and seeing is that a lot of hospital systems are, well, the students can come back. Oh, no, now they can't. And it's kind of like this back and forth, particularly with nursing students. I don't know if I see it as much with medicine and some of the other professions. And so where's the line with that? Because COVID's not going anywhere. The numbers are going up, but we still have students, and they're going to be the workforce. So, I mean, what do you think needs to happen in your setting to kind of facilitate and make sure that the students get what they need?
That's a great question, Lexi. One thing that we're seeing, our students that are able to help support the care of COVID patients are becoming experts in COVID care. And then the question is, well, what about the other factors like heart failure, like managing sepsis, like managing these other conditions that in traditional nursing education, we could provide a more broader scope. So we're thinking on that. One thing that's changing right now that I'm so excited about, large groups like the American Nurses Association, and I'm gonna pitch $1 in right now, the ANCC, and I actually get confused about this one. What's the ANCC again? Carolyn?
I think you wanted to say AACN, the American
did.
Association of Colleges of Nursing.
Thank you. American Association of Colleges of Nursing. Here's $1. That's like nursing is that acronymed out. I don't even know what half of them are. Large organizations like the American Association of Colleges of Nurses are making, are submitting and publishing white papers and guidelines on ways that we can better work with students. My grandfather is 93. He told me a story when COVID first started about, he remembers going to his church when he was a young kid. And there was a woman there who had been a nurse. She was about retirement age when he met her. And she had nursed people in the US during the 1917 and 1918 Spanish flu outbreak. And she said at the time, anyone nurse or nursing student, all hands on deck. They came into the large hospitals, the large clinics, they treated people, and my grandfather's kind of like, his mind is kind of going, but he was so clear when he told this story. And he said, I remember her saying that we worked day in, day out treating patients. And as soon as we got sick, which we all did, we picked an empty cot and we laid down. And then our friends and classmates treated us until we either died or got better. And if we got better, we got back up and we kept treating patients. I think sometimes we can take we can look at the challenge of bringing students in, and I think that's a risk worth taking, because you're right, y'all, COVID's not going away, and how do we best prepare our learners? But what are those risks,
Yeah. And Tim, I think at that time, schools of nursing and health systems or hospitals were so much closer aligned. Maybe they were actually under one organizational umbrella. and we've separated a bit. And we have to be intentional about working together. I think it's one of the things that we would all say is a highlight of being at a place like Emory, where we have this closer relationship with our health system than many of our schools of nursing enjoy around the country.
You're absolutely right. I think very few schools of nursing around the country have such a high level relationship, working relationship. And I think it goes beyond nursing. You know, I think about what are we doing with our partners at the School of Medicine, and how are we sharing our data? It seems that when COVID hit, there was this contraction and retraction back into ourselves. And now I think we're doing a better job at sharing our data and what we know. But Roxanne, any thoughts around that of like, how are we sharing data to make the right policy choices? Can we do that better?
I think we could definitely do better. And I think we need to have more data on on what populations it's affecting. I mean, I think like right now, there isn't even data on race or occupation. And I think that that is needed so that we can kind of target our interventions and resources to those communities that need it. And I think that for Carolyn, it must be as just as much as public health officials. It's so hard to come up with a decision of what to do with students, because we know that they need that interaction with other people. That's part of education, and trying to balance that out with the risks and all of the different preferences that everyone has must be just really hard.
Mm-hmm. If I switch hats for a minute and think about my clinical role, I will say, in long-term services and support, so that would include skilled nursing facilities and assisted livings, where we have a lot of data because we've had all of this intensive testing. I don't know that it's been used to support those environments as much as it has been to make expectations for them to do things that they cannot do or not resourced to do. And so, it's been interesting. I've been on the same, line of thought, which is we need more information. We need to know who's positive. We need results that are accurate and timely so that they are actionable. And we need to know different caveats of population. The one thing we focused on is age, but I don't know that we've used that information to improve the situation. So, my patients, if they happen to be in a residential community, are in such tight lockdown, and other things are increasing, including, questions around, the care that they're able to get given the resources we put in those environments, and inappropriate prescriptions for things like antipsychotic medications for people with dementia. So we're seeing a lot of disease progression that maybe, is it due to treatment? Is it due to the fact that we can't provide normal stimulating things that you need for someone who's living with that? So I think you're right. It's data, but it's helpful data.
Absolutely. And as we see these conditions change, I think about the folks that are choosing not to come and get care. A topic that we've talked about already is this idea of social determinants of health. And maybe let's dig in a little more on that to kind of define as a group what we mean by that, so our audience is clear on that. And Lexi, you had mentioned it, like, why do some people choose not to come and receive care? Do you want to touch on that?
Well, so let's talk a little bit about social determinants. So
Right.
A lot of the ways we've looked at health traditionally, you look at the individual and what they're doing and how they're managing their health. But the social determinants are the factors in, where you're born and where you live and work and play, right? And how those influence your health and your health outcomes. And so the truth of the matter is, there are a lot of different social determinants we could talk about with COVID. I think a lot of the data has shown that racial and ethnic minorities are more likely to succumb to death because of it. And when you think about it, either they don't have good access to care, they're either uninsured or underinsured in some cases. And so they don't want to come in because of the financial burden that coming into the clinic to be tested might cause, and the unexpected cost. But also, they may not just trust the healthcare system. Our country does not have a good track record with certain groups around healthcare interventions and research. And so by the time people actually get to a healthcare provider, they're way progressed in their illness. I don't think this is a COVID specific thing. This can be applied to many different illnesses. And so by the time they come in, it's a little too late to intervene, and they're more sick, and it's a bad situation. I think one of the downfalls of having the data come out, I think when they identified that COVID more disproportionately affected people of color, I feel like the rest of the country was just like, oh, well, we're fine, so let's just go and just enjoy ourselves and just do whatever we want. But those groups are the essential workers. They're the ones working in jobs where they're going to be exposed more likely. They're not going to have the insurance that they need, and then they don't trust the healthcare system. So it's a recipe for disaster.
Absolutely. And I think what more harm am I causing as a white male if I choose to walk out in public without a mask on, even knowing like, well, I got access to care, I'll be fine, right? I'm otherwise healthy. What harm am I causing to so many other people that I don't even know? And I'm not sure, as people living in the US, we necessarily think that way.
I don't think we think about one another. I think as nurses, maybe that's an example of how we can use our profession to influence our culture, because as nurses, we know that you have to think about the other person. It's not just about yourself, right? And even if you don't want to wear the mask or you feel a certain kind of way about it, for the betterment of the entire population, this is what we need to kind of get this thing under control. And I just wish that there was some kind of way we could use the data or stories, or nurses can kind of share our lens. And if we can get more people to use that lens, maybe we could kind of help address some of these social determinants and these disparities that we're seeing.
I agree. I think that's a huge culture shift, but I think nurses are primed as a profession to address that and to bring up what we need to bring up. I'm going to bring up another elephant in the room right now. And I know we have a whole episode dedicated to this and looking at race in this country. But what I call, when I talk about this, the acute on chronic race and social injustice concerns and problems we have in this country. Chronic meaning from the establishment of this country, a country based on slavery and built on the backs of enslaved people stolen from Africa to work here. Like it has always been bad. The acute being, as we reflect on the murders of Breonna Taylor, who was an aspiring nurse, the murder of George Floyd, and the list of names that go on and go on, we are reminded acutely. Now, this stress on top of the stress of COVID, in recognition of how it's affecting our communities in ways that, I'm going to speak as a white male, I don't know and I will never know. But as a nurse, and needing to recognize that there are all these other elephants in the room that we don't even know about. But how, as caregivers, do we stay connected with that and provide life-saving quality care? And how do we keep moving forward ourselves as nurses? We think about some of the psychological effects as caregivers facing people going through intense stress. Anybody have any stories about nursing on the front line, of nurses caring for people that are facing these stressors plus financial crisis? How many patients are coming in because they're like, I can't pay for it. I don't want to pay for it. It goes back to the social determinants. But how are nurses handling that? Have you all heard some stories of the front lines or had some personal experiences?
Well, I can share stories. I mean, I don't want to just dominate conversation. I mean, I don't know, Carolyn, you look like you wanted to.
Well, so, I work with the team of nursing staff at clinic, and we interface a lot with family caregivers. So, in that space, and this kind of, I guess, relates a little bit to, what is a nurse, and not that they are nurses, but they are doing the work of nurses and social workers and financial counselors, and, a very technical, they're so on edge. And so, when they're calling, so we have family caregivers who are interfacing with our registered nurse, and everything is elevated. Something that is seemingly small as, the pharmacy called and they said, we don't have any more refills. That would be in normal times, pre-COVID, you send a message like, hey, we're out of refills. And it's now like, I don't have any refills and it comes tomorrow and I don't know how I'm going to pay for them. But they don't necessarily say all of that either, right? But you feel it. You just feel it. In my world, we talk about like, what is the emotional truth of what they're saying and what is the literal truth? The emotional truth behind it is so much more loaded. And I think we have to be sensitive to that's happening for our patients and families. Sometimes we'll get together as a team and say, patients and families are really on edge. They have a lot going on. There's so much anxiety and all of this is peaking right now. And you can't talk about how we support them without recognizing that we also are vulnerable to this. We also are living this. So even though we may not be coming at someone, we're receiving it. And it's really hard not to kind of own it you pick up those emotions. They're almost contagious over the phone line. And so to be able to ground yourself, I think we've talked about self-care for nurses for a long time. And now's the time to pull those out to say, okay, what's your go-to? What's your backup method? And what's your plan C when you feel it? I mean, I feel physical reactions now when I'm reading things, when I'm listening to patients and their families. And I have to kind of say, oh, I'm feeling something. I need to stop and do whatever my thing is going to be, which might be standing on my back porch for a timer set to just breathe, or to use my Calm app, or to go hit tennis ball, whatever it's going to be. Yeah. This is the time to pull it out. So, but I don't, it's like, this is a time when the usual methods aren't working. So you gotta like go, down your list.
Yeah.
I think that this is, I'm sorry.
Go ahead, Roxana. No, yeah, go for it.
I was just going to say that I think this is the time also to become involved in politics and policy and be civically engaged. Because, we talk about social determinants of health, but I think that there's something much more deeper, and that's like political determinants of health. These are like policy issues that are driving these social factors that are influencing health. And I kind of feel like social determinants of health is kind of code word for like racism that happens in our country and around the world. So I think that, all of that frustration, we need to channel it into, having more Lauren Underwoods in Congress, to be there and fighting for the people. We need that. We have 3.5 million nurses. We are a large workforce, and we have the power, if we use it right, to make life better for all.
Absolutely. And just to clarify, Lauren Underwood is a nurse, a congresswoman, and we've only had a handful of nurses in our nation's history serving at that level of leadership. So to your point, Roxana, great opportunity there. And yeah, what can we do? Those of us that aren't in the hot zone, in the red zone, what can we do outside in the green zone to then support our folks who are right there?
That's what I wanted to get to. What is the nurse's role in the pandemic? I think when COVID first rolled, everybody's eyes was on nursing, right? But the nurses at the bedside. And as it's become more commonplace, we've kind of just geared away from talking about that. But nursing is, like we talked about in our last episode, is a very large profession, and we all have a role in this pandemic. And I think everybody's just been trying to keep their head above water, right? And survive these past few months. But now we kind of have to shift gears. Just like in research, you have the discovery phase, then you have the phase of translation. So how do we take it and do something with it? I think one of my biggest concerns for all nurses right now is the level of exhaustion that I think is pervasive across the board, as well as the level of trauma. I think trauma is affecting, I can imagine being at the bedside, seeing the stuff that they're seeing with short staffs. They have coworkers falling ill to the disease, so they're short staffed, they're under all this pressure. I'm sure some of them are thinking about their licenses. When we talk about policies, like what about state laws around licensure and malpractice, and can I get a lawsuit? So that pressure. But then for those of us in education or administration, we have the same kind of trauma and exhaustion. And so how do we ensure that our profession is able to move forward in a healthy way, right? We're bad as nurses about taking care of everybody else. And then we are just like killing ourselves. And right now in COVID, the whole entire profession is at stake. My concern is that we're going to burn out, which is going to have a lot of implications for the future of nursing, whether it's, someone like Carolyn, who's trying to place all these students with very little support and all this, one day it's this, another day it's this. How can someone sustain that? Yeah. How can we sustain our profession? And how can we get the money and get the attention on our profession? Not just because of COVID when it first started, we are still here. So, and I feel the pressure and the stories I'm hearing from nurses and practitioners is I'm tired. I'm doing my best and I don't feel fully supported, but I'm still supposed to somehow do my job.
Lexi, what do they say? Like you get on a flight, right? And the flight attendant comes out and says, if the masks drop down, what are you supposed to do? Yeah. Put yours on, before you put someone else's on. What do we do as nurses? We cover the entire plane. We make sure everyone on the plane has a mask on. By the time we get back to our seats, we are literally blue because our oxygen saturation is like 65, and then we pass out. Like, that's the heart of nursing in many ways, and that's the shift that we need. I've had the opportunity in my role to sit with nurses, to sit with technicians, other members of the allied health team. If it's 3 a.m, if it's 3 p.m, I'll go to the units and just hear stories. And some are very hard to recount because our nurses are suffering. And what I hear is, we're worried about supplies. We're worried about coming home and bringing this to our children. This is on our mind at all times. And as I hear that, I think about our current state, in which we said when COVID started, remember, like heroes, healthcare heroes, we were celebrating our heroes. Remember, people coming out in the streets around the world clapping. But you know what we're doing to our heroes right now? We as a culture, we're flexing off and furloughing our nurses because of the financial hit.
Yeah.
And we're trying to find that balance. So some of the nurses that I met with have said, what's up with that? You call me a hero 1 month and then you cut my hours the next. It's so complicated. And the tears that I've experienced from the nurses I've met, they're going to stick with me for the rest of my life. But something else that's also going to hold is that in almost every conversation that I've had with groups of nurses, someone also raises their hand and says, but you know what? I've never felt more connected with my team than I have in my entire profession. I met with one nurse who told me, and she said, sounds weird, Tim, but when I come to work, I feel safer at work because I'm surrounded by nurses, physicians that, one, believe in science and know the science, and so we know how to stay safe. And we're taking care of each other. She says, I feel less safe when I walk outside of these hospital walls, even though our hospital is full of COVID right now. And something that we're learning more and more is this sense of camaraderie and sense of community that is coming forward. Now, I don't want anybody watching or listening to get me wrong to say, okay, we're fine then, because we've got a sense of community. We've got so much work to do. But I think as we also think about the suffering that we're experiencing as a profession, as a world, we also need to look at, some people call it post-traumatic growth. What are the strengths that are arising?
Mm-hmm.
What can we take forward? And also, as we notice that moment of strength, as I am exhausted, Lexi, when you reach out to make me smile, can I take that on? And then no, put that in my bank, then when you're exhausted, I can do the same.
Yeah.
It's not we are first, we are number one sort of thing. We are we. And I think if we look at that connectivity that we're learning, I don't know, check me on this, but I think that's the only way we're going to get through this.
No, and I think there's also a sense of, when we do have people who recover, when we do have a success story where we catch someone because they called the nurse triage line and we got them to avoid, higher levels of care, where we can intervene and be successful working with, we don't make people better. So I hesitate to say that, but, we can, alongside them, get them to a recovery place where they're able to return to whatever that looks like for them. I mean, that sense of like pride, and not justified, not for the individual, but just to feel good that you're making a difference. I mean, this notion of, and this is kind of the core why people go into nursing, right? They want to help other people in a way. They want to do something that matters. They want to do work that matters. And so you don't always get to see that in a positive way. And so we need those. That's another thing you take in your bank, right? Like, I got a success story. Like, I'm going to need to hold on to that one for a minute.
Yeah.
I feel that way when a baby comes earthside. If a mom is scared that whole time, and then when that baby's born and you see the joy, and even though they have to quarantine at home and people can't come visit them, and postpartum is a hard time where you normally have that network, and to see them get through it and have that resilience. I mean, y'all are 100% correct. That is the reason why we're able to keep going. And I wish the world could see that fully, that I wish we could show them that.
In some of our hospitals, we're having sort of a birthing ceremony, if you will, that I think of Emory St. Joseph's, for example. When a patient survives and when they're being discharged to home, they call what they call a code Rocky. Right? In hospitals, we have code blue, and that means someone's dying. We have code neo, and that means there's a complication in the birth. Neo meaning for neonatal. And for code Rocky, when someone is discharged at home, literally when they're being wheeled out of the hospital, they call a code Rocky over the loudspeaker. Anyone that's free comes down to the exit of the hospital, and they play that song from Rocky. You know, dun,
really?
Dun, dun,
yeah, what is that one?
Dun, 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 dun. Yeah, right. It's a Rocky fight song. And they blast it in the hospital. That's awesome. The opportunity for docs, for nurses, for the entire team to see the product of their exhausting work that they saved a life. And it is powerful, powerful, powerful. And nurses say how meaningful that is. Nurses tell me how meaningful it is that when family members and patients, when family members can't come in, the nurse also serves the role as the family member, the loved one at the bedside. And that's why we're here as nurses, I think.
Yeah, I wish we could do that. I love that code Rocky thing. Like, that needs to be like a nationwide. We need to celebrate all aspects of nursing. You know, when we get Carolyn, when you get we just had a graduation the other day. Another group of students completed their licensure programs, right? You were successfully able to move them through COVID. Like, we should have been having a party. You know, that's a big deal.
Yes, yes. We wanted a champagne toast, but which is okay. You can do it individually.
And how do we then draw the line from our researchers to say, by what we learned in research in Roxana's office, to translate to educators, leaders in a nursing school, Carolyn, to translate to instructors and practicing clinicians, Lexi, to say I translated this, to translate to our health system to say, through all of this work, we saved a life. And if we can map that out, if there are any nursing students out there listening can help design that map for us, you got yourselves a job.
Yeah.
Y'all, we are at time. I feel like this conversation could go on and on and on. And because it needs to go on and on, we're going to take a minute with each of our future episodes to touch on where we are with COVID, because it's real and it's and we need to keep talking about it. We need to keep talking about it. Yeah. Future episodes, we're going to touch on technology and nursing. We're going to touch on nursing education. We're going to talk about race. We're going to talk about immigration. We're going to talk about global health. We got some other topics we don't even know what we're going to talk about yet as we continue to have these conversations. I'd love to make a quick announcement. At the Emory Nursing Experience, we've got free courses on COVID, 2 of them right now. So if you go to Emory Nursing's website and Google Emory Nursing Experience, search for it on the website, you can get a couple free courses. We always welcome feedback. We always welcome questions. We welcome your voice as we work together to elevate the voices of nursing from all the spectrums. Contact us on social media. Stay in touch. And people, wear a mask. We will see you all next episode. Thank you all. Stay safe.